I'm going to talk about the perinatal periods of risk data analysis that we use for the Ramsey County Birth Equity Community Council. PPOR stands for Perinatal Periods of Risk. PPOR helps communities understand some of the reasons infant and fetal deaths are happening. It was modified by CityMatch for the U.S. based on a process developed by the World Health Organization. CityMatch is a membership organization of city and county health departments. They provided technical support for the first time we went through this, and technical support for the whole BEC project, and they continue to answer questions as we need them. I'm just going to talk about the data right now, not about the entire BEC project. So there are two phases to PPOR, and actually there are really three, because preparation of the data is the most time-consuming part of the process. But in phase one, we're looking at what is happening. Which of the 4 perinatal periods of risk have the most deaths and the greatest inequities? In phase two, we do a deeper dive into the periods with the greatest inequities. We look at why the deaths are occurring. What are the contributing causes of death? What are the contributing risk factors? What are the possible impacts of addressing the causes and risk factors? In PPOR phase one, we fill in the fetal infant mortality maps. We use vital statistics data from MDH, including birth records and infant and fetal death records. The analysis we're currently doing includes records from 2014 to 2018 from Ramsey and Hennepin counties. The analysis begins by dividing infant and fetal deaths into 4 perinatal periods of risk based on birth weight and age at death. This is useful because the causes of death tend to be similar within each category. So in the image, you can see the 4 categories and some of the factors that would be considered when doing a phase 2 analysis. On the top is the blue box. That's called maternal health prematurity and includes all very low birth weight babies, those that weigh 3.3 pounds or less, regardless of age at death. The 3 periods on the bottom include babies who weighed more than 3.3 pounds at death, but different age groups. So on the left, the maternal care period, the pink box, includes fetal deaths and stillborns. The newborn care period, the yellow box, includes babies who died between 0 and 27 days after birth. And the infant health period, or the green box, includes babies who died 28 to 364 days after birth. PPOR has an underlying assumption, and that is if one population can have good birth outcomes, then all populations should be able to have the same good birth outcomes. For this reason, PPOR compares the study group, the group experiencing the inequity, to a group that has optimal birth outcomes. The group with optimal birth outcomes is called the reference group. So we have 2 study groups currently, African American US-born and Black foreign-born women. They are or were residents of Ramsey or Hennepin counties at the time of delivery, and they delivered between 2014 and 2018. Our reference group includes white non-Hispanic women in the same location and time period. We included data from Hennepin County because the analysis requires a minimum number of deaths, and we weren't able to do the analysis with just Ramsey County. I wanted to briefly talk about infant mortality rates. So an infant mortality rate is a number of deaths per 1,000 births in a given time period. So for example, if there are 5,000 births in 1 year and 45 of those babies die, it's 45 divided by 5,000 times 1,000, which equals 9. So the infant mortality rate is 9. 9 babies died for every 1,000 born. It is not a percentage. The same thing expressed as a percentage would be that 0.009% of infants died. So PPOR is different than just looking at an infant mortality rate for 2 reasons. One is that PPOR considers fetal deaths also. And secondly, PPOR calculates these rates for each of the 4 periods. So we fill in the fetal infant mortality map for each study group and then compare those to the reference group. Each box shows the rate of death per 1,000 births in each of the periods. We subtract the reference group rates from the study group rates, and we get the boxes on the right. This is called excess mortality. It's also called the opportunity gap. It shows the difference in rates between the study and the reference groups. In the 2014 to 2018 data, the largest gap for both study groups is the blue box, maternal health prematurity, the very low birth weight babies. And so let's just look at an example. So if we look at the top left blue box, that's African American mortality rate. We see for the blue box, it was 4.51 per 1,000 births for babies delivered to African American women. In that same time period, the rate was 1.59 per 1,000 births for white women, the reference group. The difference then is 2.93, and that is the number that we would call excess mortality or the opportunity gap. And as you can see, it's the largest number there, so that we might think, well, maybe this is the area we're going to focus on. This is another perhaps starker way of looking at the same data. This shows the number of babies that would have lived if the rates for Black women, U.S. born on the left, foreign born on the right, had been the same for white women. And I think the numbers speak for themselves. And this is another way of visualizing the data in these pie charts. This is from our 2011 to 2014 analysis. 2014 to 2018 is a bit different, but the pattern is similar. And I wanted to show this for a couple of reasons. First, you can see that the pies are quite a bit different between babies delivered to U.S. born and foreign-born Black mothers. For U.S. born women, the infant health period was large, but was the smallest for foreign-born women. For foreign-born women, the newborn care period was large, but small for U.S.-born women. The point here is simply that the data might provide information that leads to different types of actions by separating these two populations and study groups rather than looking at them together. The other reason I wanted to show this is that we decided to do the PPOR Phase 2 analysis on the infant health area for U.S.-born women in this first go-around in using the 2011 to 2014 data, as it was the largest gap. So for Phase 2, CityMatch developed protocols for analyzing the data for each of the 4 periods. They provide a variety of recommendations and tools to help guide the analysis. So when we were using the 2011 to 2014 data, we decided to look at the green box, infants born to U.S.-born African-American women weighing more than 3 pounds 5 ounces, and they died between ages 28 and 365 days. The Phase 2 PPOR analysis showed that 69% of the excess mortality in the infant health category was due to sleep-related deaths. The rate of sleep-related deaths was 3.5 times greater for U.S.-born Black women than for white women in Ramsey and Hennepin counties. If the rate of death for infants born to Black U.S.-born women had been the same as the rate for white women, 14 of the 20 babies who died from sleep-related causes would have lived. In a review that MDH did of 53 sudden unexpected infant deaths in 2014, they looked at a wide variety of sources: birth death certificates, law enforcement, autopsies, death scene investigations, medical records, child death review reports. And just a couple of quotes from that report. There was not a single sleep-related death in Minnesota in 2014 in which the infant was found in a safe sleeping environment as defined by the AAP. More specifically, every case involved either soft bedding or a shared sleep surface. And another quote from that report: our review of medical records from SUID cases suggests that parents often receive a clear message about placing infants to sleep on their backs, but less clear messages about the dangers of bed sharing and soft bedding. So we're moving on to 2014-2018 data, where the blue box, maternal health prematurity, was the largest area for both U.S. and foreign-born women. These are the very low birth weight babies that die in utero as newborns or as infants. There are some considerations in the phase 2 protocol for this period. Causes of very low birth weight fetal and infant deaths are complex and reporting is inconsistent. And for this reason, in the protocol developed by CityMatch, we don't look at cause of death in the birth record. Instead of the causes, we look at which risk factors contribute to those deaths. In addition, there are two distinct pathways to very low birth weight deaths. The first step in phase 2 for maternal health prematurity is to figure out which of the two pathways the study group is on. This is a tale of two cities, Tiny Baby City and No NICU City. And I'll just say it's called No NICU City because it's a pattern that you would expect to see in, for example, a rural area that doesn't have the same sort of medical care that's available in an urban area. So in Tiny Baby City and No NICU City, they both have 1,000 births. Both cities have 10 very low birth weight deaths. So the difference is that Tiny Baby City had 100 very low birth weight births and No NICU City had 10. In Tiny Baby City, actually 90% of the very low birth weight babies survived. In No NICU City, none of the very low birth weight babies survived. Or to say it, the opposite way, in Tiny Baby City, 10% of the very low birth weight babies died. In No NICU City, 100% of the very low birth weight babies died. So what's happening? What's different? In Tiny Baby City, most very low birth weight babies survive, but a lot of them are being born. In No NICU City, there are very few very low birth weight babies, but they aren't surviving. So the objective in Tiny Baby City is to reduce the number of very low birth weight babies, while the objective in No NICU City is to improve survival of very low birth weight babies. So what do we need to look at? In Tiny Baby City, we need to look at what factors impact very low birth weight births. And in No NICU City, we need to look at what factors impact survival of very low birth weight babies. I don't know if these are CityMatch terms, but the Tiny Baby City pattern is called birth weight distribution, and the No NICU City pattern is called birth weight specific mortality. And who is at risk? For Tiny Baby City, all pregnancies are at risk of being very low birth weight. For No NICU City, it's the very low birth weight births and fetuses that are at risk. So what's going on in Ramsey and Hennepin? Both things. The Kitagawa analysis, which CityMatch helps us do with a tool they provide, lets us determine which pathway the excess deaths are on. For U.S.-born Black women, we see the same problem as in Tiny Baby City. There are too many very low birth weight babies being born. 90% of the very low birth weight deaths can be attributed to there being too many very low birth weight babies. The objective for this group is to reduce the number of very low birth weight births. For foreign-born Black women, both things are happening, but over half are like No NICU City. There aren't as many very low birth weight babies, but fewer of them are surviving than you would expect. So here the objective is to improve survival of those babies. To reiterate, with maternal health prematurity period, we look at the risk factors that may have contributed to the outcome. We do not look at the cause of death. Population attributable risk, or PAR, is a way to determine the prevalence and the strength of the association between a risk factor and an outcome. PAR has an intuitively meaningful interpretation as the percent of the population that would be prevented from the poor outcome if the risk factor were eliminated from the entire population. So the higher the number, the greater the association. PAR can help to narrow down the possible associated risk factors with the caveat that birth records provide a limited view of the total experience of pregnant women and birth, and risk factors interact with each other. So it's one piece of information. So we looked at a lot of different risk factors in the birth and infant and fetal death records, medical conditions, birth conditions, maternal complications, complications for the baby, where was the baby born, was the baby or mother transferred, smoking, weight gain, age parity, C-sections, toxicology testing, prenatal care, and plurality. among probably a few others. So again, CityMatch provides us with tools to help us do this analysis. Since US-born and foreign-born women are on different very low birth weight paths, the population that we're looking at and the bad outcome differ. For US-born women, the tiny baby city pathway, the population is all pregnant women, and the bad outcome is a very low birth weight birth. We're no longer considering death. We want to understand what's associated with very low birth weight births. And I think there were probably in this data set about 12 to 13,000 births to US-born Black women in this time period. For foreign-born women, the no NICU city pathway, the population includes all very low birth weight births. This is a much smaller population. I think it was under 300. And the bad outcome is death. We want to understand what's associated with very low birth weight babies dying. So right now we're looking at data for US-born Black women. The risk factors that appear to have the strongest association to very low birth weight include hypertension, and I combined essential gestational and eclampsia into one variable for this analysis, multiple births, cigarette smoking, and not being on WIC. But the risk factor that appeared to have the strongest association was whether the mother had toxicology testing. This variable does not indicate if a toxicology test was positive, just if it happened. It's not really, the birth records, there's not really any way to determine the outcome of a toxicology test using the birth records. So our data set, our data set indicated that African American women are tested for illicit drugs 7 times more frequently than white women and 8 times more frequently than foreign-born Black women. So in addition, we decided to look at some variables in the birth record that might be associated with substance use. We know that substance use is a risk factor for preterm labor. So we looked at the administration of tocolytics to prevent preterm birth and then compared that to whether or not a mother who was given tocolytics was also tested for illicit drugs. 39% of US-born Black women where it indicated tocolytics were administered also had toxicology testing. Only 4% of foreign-born Black women and 14% of white women given tocolytics also had toxicology testing. So US-born Black women are being tested way more frequently. So now we're looking at the foreign-born. Although the foreign-born Black women fell on both the very low birth weight pathways, we have so far looked at the birth weight specific mortality pathway, the no NICU city pathway. The population we consider is much smaller, very low birth weight deliveries, and the bad outcome is death. There were 273 very low birth weight deliveries, and of those, 131 died. The 2 risk factors that had the highest PAR were the presence of congenital anomalies and delivering at a hospital without a level 3 to 4 NICU. I did reach out to the Birth Defects Registry a couple of years ago to get data on the incidence of congenital anomalies in the babies of foreign-born and US-born Black women. They did a security update on our email, and I believe all of those emails are gone now. But I do recall that there did appear to be a higher incidence of congenital anomalies in the babies of foreign-born Black mothers. So PPOR raises questions that might warrant further investigation. For example, for US-born mothers, what's happening with the toxicology testing inequities? And we could look further into hypertension and very low birth weight. And these are just some examples of what we could do related to this data. For foreign-born mothers, we might ask, why are we seeing no NICU city in a metropolitan area that has 7 or 8 level 3 and 4 NICUs? What's happening with the congenital anomalies? Why might there be more in this population? And what else might be happening related to the care of the mothers or babies? So PPOR is really one of many sources that inform BEC. And so it's just a piece, it's a quantitative piece of the puzzle.